Okay, and now this is going to be part two. Sorry, my internet dropped off. This is going to be part two of the Chapter 5 lecture. So picking up where we left off, the hypertensive disorders of pregnancy, the second one being that gestational hypertension. And it's hypertension that first occurs during pregnancy. So no previous history of high blood pressure levels, they become pregnant, and now they have consistent high blood pressure readings. They're also at that same increased risk for developing preeclampsia later in pregnancy and actually chronic hypertension later in life. And the treatment for gestational hypertension is similar to that for the chronic hypertension, so close monitoring of diet, potentially a sodium restriction, really depends upon their own personal dietary intake patterns. And lastly, we have the last two disorders. They're actually two separate things, preeclampsia and eclampsia. So eclampsia is the much more severe version that includes seizures. But preeclampsia has the high blood pressure readings, but also you have some organ dysfunction as well. Typically, you'll see severe blurred vision, consistent headaches, high blood pressure readings, and most importantly, the spilling over of protein in the urine. And like I said, eclampsia is even more severe than that, which may include seizure activity. Now, this is a pregnancy-specific syndrome, so we don't see it in other populations. And it occurs in 4% of first-time pregnancies. And, you know, having preeclampsia previously increases the risk that it will occur in later pregnancies. Signs and symptoms can range from mild to severe, as do the health consequences. And we really don't know why this occurs. Once again, this is something that just happens in pregnancy. We don't really know why it may happen. So some of the characteristics of preeclampsia, as we've said with all hypertensive disorders, you have that oxidative stress, inflammation, and endothelial dysfunction, potential platelet aggregation and blood coagulation, blood vessel spasms and constriction. You may see insulin resistance, increased blood pressure, adverse maternal immune system responses to the placenta, and elevated blood levels of triglycerides, free fatty acids, and cholesterol. So some nutritional recommendations and interventions for preeclampsia. It's most important to note with preeclampsia that dietary interventions should happen even before pregnancy, which is kind of almost impossible considering half of pregnancies in this nation we know are unplanned, right? So but however, research has shown that by being preventative, we give women the best opportunities to decrease the body weight, decrease those stores of central body fat, and consume a diet that reduces some of that inflammation and oxidative stress. However, if you're not able to be preventative about it, we want to try to start treating nutritionally as soon as possible. So getting adequate calcium and vitamin D, using a multivitamin if necessary, 5 or more servings of colorful fruits and vegetables, adequate fiber intake, and making sure that they're following MyPlate or some basic food recommendations, exercise, and weight training. So on to the next topic, diabetes and pregnancy. We know that diabetes is a leading complication in pregnancy and has 3 main forms, type 1, type 2, and gestational. And we're going to start with gestational because it is specific to pregnancy. So women developing gestational diabetes appear to be predisposed to insulin resistance and have impaired insulin production. It happens in about 2 to 12% of pregnant women, but it accounts for 88% of all cases of diabetes in pregnancy. So if you're talking to somebody that is pregnant and diabetic, chances are they're dealing with gestational diabetes. Now, some of the risks related to gestational diabetes, you have spontaneous abortion, stillbirth, congenital anomalies, and neonatal death. And some of the risk factors, it could be genetic, it could be environmental triggers, but we know specifically that extra body fat, unhealthy diets, and low physical activity levels increase your risk for gestational diabetes. So how do we diagnose? All pregnant women are typically screened at their first prenatal visit with a hemoglobin A1C. Now remember, that's the look at your blood glucose levels over a 3-month period to see how consistent they are. A fasting plasma glucose, so not having eaten. A 2-hour glucose load is typically done later in pregnancy. And of course, symptoms of hyperglycemia if they're present, and then just doing a random plasma glucose. So just meaning they've eaten at some point that day and where are they sitting right now. Now, all pregnant women without diabetes should be tested with a 75-gram oral glucose tolerance test at about 24 to 28 weeks. So what typically happens with this is you're brought into the doctor's office first thing in the morning before you've had breakfast or anything like that, and you are gone ahead and given the fasting plasma glucose. They go ahead and take your blood before you've eaten. And then they give you this 75-gram oral glucose to drink. It's fun, it's thick, it's like sweeter than Kool-Aid. And you drink it, and then an hour after you drink it, they go ahead and test your glucose. They want to see it under that 180 milligrams per deciliter. And then you sit in the doctor's office again for another hour, and they test again at the 2-hour point. So basically, they're looking to see where you were at before you took the glucose, and then how your body dealt with that huge dose of glucose. So how do we manage gestational diabetes? Well, similar to type 2 diabetes, both are both insulin resistance related. Our mainstay is medical nutrition therapy because we want to keep those blood glucose levels as normal as possible. We do that through diet and exercise. One important thing to note is we do have to be wary of using a very low caloric intake because it can elevate blood ketone levels and that can actually affect the baby. Now, if we need an oral medication, metformin or glyburide is typically used to decrease insulin resistance. Insulin may be used if necessary, but typically we're going to start with diet and exercise, then metformin, and insulin if absolutely necessary. We also know that exercise, particularly regular aerobic exercise, is beneficial with gestational diabetes. And if we were to see a patient with gestational diabetes, our nutritional management would include assessing those dietary and exercise habits, developing a diet and exercise plan. Once again, looking at weight gain, we don't want them to gain too much weight. But we're also going to look at blood glucose levels, if they've been keeping their own logs at home, if they're spilling over any ketones in their urine, and ensuring that follow-up occurs not just during the rest of pregnancy, but also after pregnancy, because remember, they're at an increased risk for developing type 2 diabetes. All right, so what do we do with our patients that have gestational diabetes as far as diet? We're getting in those whole grains, right? Those low glycemic index foods, minimally processed, nutrient dense, limited intake of sugars, unsaturated fats. And one thing we're really thinking about is splitting that carbohydrate intake throughout the day with regular meals and snacks to ensure that we're not causing our blood glucose levels to decline and increase rapidly. Now, the Institute of Medicine says that all pregnant women should receive at least 175 grams of carbohydrate daily. However, it is common for the macronutrient distribution for carbohydrates for those with gestational diabetes to be about 45%. So you're looking around 270 grams daily. So 45% of their calories should come from carbohydrates. It should not drop any lower than that. And once again, making sure that their carbohydrate intake and their calories are spread throughout the day, and then also make sure to include a nighttime snack because we don't want to go into a hypoglycemia effect overnight. So we need to be thinking about how many calories and what the caloric need is in women with gestational diabetes. It's going to depend upon their current weight status, and you'll be doing that calculation just to see exactly what they need. So how do we prevent gestational diabetes? You're thinking about getting pregnant, you're concerned about this, maybe it runs in your family. Well, reducing extra weight and increasing physical activity and decreasing insulin resistance prior to pregnancy are great ways to decrease your risk factors. Now, type 2 diabetes in pregnancy. Now, these are the people who come into pregnancy already having type 2 diabetes. And once again, we want to maintain normal glucose levels, just the same as gestational diabetes. We don't want that rapid decline and increase and decline and increase throughout the day. Because hyperglycemia and hypoglycemia pose threats to both mom and baby. Now, unfortunately, type 1 diabetes is even more hazardous than having gestational or type 2 diabetes during pregnancy. The mother is much more at risk for kidney disease, hypertension, and preeclampsia. The newborn is at risk for mortality, being low birth weight, large for gestational age, having hypoglycemia within 12 hours after birth. And what it is that's good control of blood glucose levels again, which is a little bit more concerning because we know the body cannot produce insulin in type 1 diabetes. So the nutritional management is making sure that we're controlling blood glucose levels. They're getting in enough calories, enough nutrients. They're achieving that recommended weight gain. And we're closely monitoring their glucose levels, their intake, their exercise, and insulin at home. So multifetal pregnancies. U.S. rates of multifetal pregnancies have increased in the last few decades, mostly due to those assisted reproductive technologies, women having babies at progressively older ages, and weight status changes. So just important information just to know about what a multifetal pregnancy is. You have the dizygotic, where 2 eggs are separately fertilized, and the monozygotic, where 1 egg is fertilized. This is one of the illustrations from your book about the differences in amniotic sacs and placentas during a twin pregnancy. So there's the possibility, as you see here in picture A, that you have 2 separate amniotic sacs with 2 separate placentas, so babies are being fed differently, right? Then in drawing B, you have where they're sharing 1 amniotic sac and placenta. And then drawing C, you have 2 separate amniotic sacs and 2 placentas that have kind of more, they'll grow into 1. All right, so how do twins and triplets grow? Well, there are some weight gain rate variations. Typically, they're about the same until 28 weeks of gestation, and then you might see the rates of weight gain begin to decline in twin and triplet fetuses at that point and remain even lower until delivery. Another thing to be cautious of and aware of is what's called the vanishing twin phenomena, where there is a disappearance of one of the embryos within 13 weeks of conception. It's not unusual. About 6 to 12% of pregnancies actually begin as twins, but only 3% result in the birth of twins. So multifetal pregnancy definitely has its own risks for mothers and fetuses. We have table 513 in the book that goes through those a little bit more in depth. Also, table 514 and table 515 let you take a look at birth weight and gestational age at delivery for the differences in having a single fetus, twins, or triplets. And then the differences in that weight gain depending upon their gestational age and weeks. So the outcome of a multifetal pregnancy really relies on a good weight gain. And weight gain is going to depend on the pre-pregnancy weight. So your normal weight gain is a little bit more significant than a normal single fetus pregnancy, because the normal gain can be anywhere from 37 to 54 pounds. And you're talking about 5 to 7 pounds in the first trimester and 1 to 2 pounds per week in the second and third trimesters. And weight gain in a triplet pregnancy is somewhere about 50 pounds. Clearly, you're going to have a high caloric need. You're going to increase your essential fatty acids, your iron and calcium, but we don't really know if there's any difference in needs in vitamin and mineral supplements at this point. One table that might be helpful to look at is 517 because it indicates the best practice that we know today for nutritional recommendations for multifetal pregnancies. So HIV and AIDS during pregnancy. The treatments of the HIV and AIDS needs to be before, during, and after pregnancy. Because remember, the transmission of the HIV virus during pregnancy and delivery is a major route to the spread of the infection. About 20% of children with HIV are infected during pregnancy or delivery, and 14 to 21% during breastfeeding. So we want to make sure mom is taking her medicine before, during, and after. And some of the consequences, infection does not appear to be related to an adverse pregnancy outcome. However, there are nutritional factors that change during pregnancy. Their needs increased, especially in advanced stages of the disease process. Remember that those with HIV and AIDS already have poor nutritional status. They have compromised immune function. And so you're already talking about nutrient losses and fat malabsorption and inflammatory responses, lean muscle mass. So you're going to have to worry a little bit more about these pregnant women ensuring that they get enough calories and vitamins and minerals. Eating disorders in pregnancy, they're actually fairly rare because most females with such disorders are actually considered to be subfertile or infertile. And if you think about that, that makes sense. We talked about earlier in the semester about the female athlete triad and how that often goes with the lack of a menstrual cycle. And so when you have anorexia nervosa, a lot of times you have those decreased calcium and you have a lack of menstrual cycle, so you're actually not able to conceive. But for those that do conceive, your eating disorder symptoms often subside in second and third trimester, but return after delivery. And the most commonly observed eating disorder among pregnant women in the United States is actually bulimia. So some of the consequences that we may see as a result of an eating disorder during pregnancy is spontaneous abortion, hypertension, preterm labor, anemia, urinary tract infections, just difficult deliveries overall. For treatment of women with eating disorders during pregnancy, we want to make sure that we're treating them with a multidisciplinary team. A lot of times that happens through a clinic or a specialist, including a psychologist or a psychiatrist as part of the process to talk about behavior modification, body image issues, things like that. But our ultimate goal would be appropriate weight gain and improving that nutritional status. So fetal alcohol spectrum disorders, the most severe being fetal alcohol syndrome, which is actually that you see actual physical features as well as changes in the organs themselves. So with a child that has fetal alcohol syndrome, you normally see a flat mid-face, abnormally shaped ears. There's typically a smooth ridge between the nose and the lips. But you can also see things like growth problems, nervous system abnormalities, and social skills, intelligence tests decrease, things like that. So fetal alcohol syndrome on the spectrum is the most severe. And then the next down, alcohol-related neurodevelopmental disorder, is actually somewhere in the middle there. You typically won't see the physical facial features that you'll see with FAS, but you'll possibly see some of the growth changes in the central nervous system abnormalities. And then with the alcohol-related birth defects, you may see some organ malformations, things like that. Once again, being more on the mild side of the spectrum. So recommendations concerning alcohol intake during pregnancy. The general recommendation at this point, despite some conflicting evidence, is that women do not drink alcohol at all while pregnant. This is often disputed, or people say a little bit's fine, or you'll hear people say a glass of wine. But our research shows that the best thing you can do is just abstain unless your doctor recommends you do something else. So nutrition in adolescent pregnancy, still something that definitely needs to be considered, because even though teen pregnancy has been declining, we continue to be the highest country of the developed countries with rates of teen pregnancy. And we know that adolescents who are pregnant are actually at a higher risk for clinical complications compared to a normal adult woman. So like I said, we've seen a decline in the past 20 years, but we're still the highest. And one of the biggest issues is the fact that during adolescence, you're going through an extreme growth period and height and weight anyways. And so that often is done at the expense of the fetus. So some of the risks, you can see that low birth weight, the perinatal death, an increased risk of having a C-section, preeclampsia, iron deficiency anemia, especially since we already see that a lot of times in teen girls, poverty, and poor dietary quality. Specifically, if we have an obese adolescent who is pregnant, they are at an even more increased risk for the hypertensive disorders, gestational diabetes, and excessively large infants. And so what do we do? What do we recommend for pregnant adolescents? Well, they're going to need more calories to support their own growth as well as the fetus. And lastly, just a note in the book about evidence-based practice. So remember, this definition is very important, specifically in our field and other medical fields, that evidence-based practice is supported by scientific evidence, right? And it means that it should be questioned and confirmed to represent what's best practice insofar as that it can be determined. So definitely read that section in the book and make sure you understand what an evidence-based practice is. All right, and that concludes our Chapter 5 lecture. So it's been in 2 parts. I will post 2 YouTube links of this. And don't forget to go ahead and take your exam. Some of these things will be on the exam. I would go ahead and take a look at the YouTube video that also breaks down the important slides of the PowerPoints for all 5 chapters of things you should know. It may help you narrow down a little bit more what you need to study. I'm also welcome to take any questions via phone or via email if you have any questions about this lecture.